Hi, everybody. Hi. Welcome. You know what tonight is? It's almost halfway through this year of 2015, and it's also our 23rd program of the year, and we're scheduled for a total of 46 so far this year. 46 programs in 52 weeks. When do we sleep, right? So, anyway, for those that don't know, my name is Stuart Schlossman, and yes, president and founder of this great organization that we call MS Views and News. Why? Because we're giving you views and we're giving you news, and it's mainly the news that we want you to know about. All right, before all this other chatter is going to happen tonight, I ask everybody here, along with me, to thank Teva Neuroscience, because they are the ones that gave us the funding to do tonight's program. So we want to thank you all. I want to thank Teva. You know, we rely on the pharmaceutical dollars to do our programs, and the pharmaceutical industry actually wants you all to learn from these types of programs. Whether it be MS Views and News or another patient advocacy organization, we are the ones that are providing you with information that you need to learn and help you moderate yourselves and your lives with multiple sclerosis. If you're the caregiver, it's great that you're attending these programs as well, because we actually want you to know even more than the patient, because the patient is going to need you to help them possibly down the line. Okay, going a little bit further now. MS Views and News, as I mentioned, there's over 150 videos on the YouTube channel, and that's because since 2010, when we began, we have done over 160 programs in just 5 years. And again, that's a great thing. This year, as I mentioned, we're doing number 23. We're on the path to do 46, possibly a few more. Maybe we'll do 52. That would be rough, huh? Good smiles out there. Tonight's format, for those who haven't seen what's been on the table, it's at the centerpiece. I see one right there. It's never been looked at. You don't want to look at it? You don't want to see what's doing tonight? Okay, there you go. All right, so first speaker is Brian Steingo. For those that know, the neurologist. Okay, great. That's right, it's nice to clap, come on. There you go. All right, next up we have Rhonda Freeman. She's a PhD neuropsychologist, and she's going to speak with you about the benefits of the neuropsychological testing, how it relates to multiple sclerosis, testing, assessment, and other things. You would think I know how to say that word by now. And then we're going to have Jeffrey Siegel, and many people have seen Jeff do his antics and other things that he does to help you stretch out, get rid of some spasticity, help you relieve your bodies of pain that you might be feeling. So Jeff will be up here last. And now I'm going to ask Jennifer Falk, who's our social worker. For those who haven't heard, yes, we have a social worker now. And Jennifer Falk is with us, and she's going to speak to you for a few minutes, and then she'll introduce the speakers again. Thank you.
Great. Thank you, Stuart. Good evening, everyone. Hi. My name's Jennifer Falk, and I'm a social worker. I have my master's degree in social work, and I've chosen to make social work my focus of social work, to working solely with the MS community. So I work with MS patients, with their family members, and with everyone that is impacted by living with MS. So MS Views and News is growing, and they recently have set up a 1-800 helpline where I am on the other end. So the paper that I put out in front of you is my contact information. And I get calls every day with people living with MS that are asking questions, that have an issue, something's come up new, they want information, and I'm able to give them that information. So that's serving the state of Florida. So you all are welcome to call me. And you may not have any issues now, but keep my number, because you never know. Sometimes something comes up, a change in insurance, a need for financial assistance, a change in your formulary, many different issues that I can help you with. And you can kind of see that listed down the side of the paper here. So I hope to hear from all of you soon. And we've got a great program lined up today. So I think Dr. Steingo's here, coming on in. Dr. Steingo? Or he's outside. You want to come on up? No? You're up. Thank you, guys.
ready to go. Thanks for whatever you said, Jennifer. I'm sure she said something good. So these programs, you know, Stuart's put together, and we try and put things out that are interesting to you. In front of you at the end of the night, there is a sheet to fill in of things that you'd like us to talk about. That's very important because we can put new items in and discuss different things according to what you fill in. Otherwise, we're going to go over some similar things, and we speak in different areas. So this very similar program we just did last week in Fort Myers. I don't think anybody here was in Fort Myers last week. Anybody here in Fort Myers last week? So nobody has seen this program unless you saw it on YouTube. I don't know, is this on YouTube yet? It will be. So it's not. So nobody's actually seen this exact program. But components of it, pieces of it have been presented at other times. For example, about a month ago in Boca, we did a part of this. Several weeks before that, we did another part of it in Sunrise. So we try and put them together just to kind of keep it a little interesting. Some people come here for education. Some people come here for revision. Some people come for the meal. Sure, many people come for the meal. Some people come here for support, meet people as part of a support group. So there's many reasons why you could be here, but it's very important for us. We like your feedback so we can, you know, bring in new items. So one of the items we're going to talk about tonight in the second half of this is going to be the communication tool about how you improve your doctor visit, which is obviously a most important time in the management of your MS. And this is the beginning over here. We're going to talk about MS in general. And you have seen this many times, but we'll summarize. You know that MS occurs in the U.S. in about 400,000. Does this come off? Yeah, there we go. Oh, but like how far can I walk from here? Can I like walk over here somewhere? No, I can't. I'm chained. I'll probably get shocked if I step off the stage, right? So, okay, so MS in the U.S., this number, you've seen this number for 100 years, that in the U.S. there are about 400,000 people with MS. It's probably closer to about 500,000 people in the U.S. So that's a general amount of about 1 in 1,000 in the general population, about 1 in 1,000. And so you're going to see, the reason I'm throwing out that number to you of 1 in 1,000 is that because soon you will see about the genetic aspects of MS. We're going to talk about that a little bit too. And remember that number of 1 in 1,000. About 2.5 million people worldwide. So MS is more common in females than males. And this is the general fact about all autoimmune diseases. Autoimmune diseases in general are more common in females than males. And the incidence of MS in the world is rising. MS is increasing in females, not in males. Especially in females, the incidence of MS is rising. So that ratio that you see of ratio of females to males of about 3 to 1 is in fact increasing over time. Then there are racial factors, right? That MS is seen in certain races more than others, and it's seen in certain areas more than others. So there's a whole bunch of things that we're trying to learn about MS. And typically, you know, the typical age group is 20 to 50, but MS has been described in infants, and MS has been described in older people. And so this is what we currently think about what causes MS. We're not sure, but we think there are autoimmune facts, so-called immunological and genetic factors that are involved. So if you have a look at the left-hand side over there at a genetic predisposition. So I told you before that in the general population, the incidence of MS was 1 in 1,000. So look on the left-hand side. Look actually at the bottom point. It says the risk of MS in the general population is 0.1% or 1 in 1,000. So move one step up and you'll see that MS in first-degree relatives is 3 to 5%. So you go from 0.1% in the general population to your family members that have a risk of 3 to 5%. That is 30 to 50 times higher than the general population. So maybe you could say a 3 to 5% risk is not that high, but it's 30 to 50 times higher. And if you have a twin, especially an identical twin, the risk is about 30%, a much higher risk. So there's no doubt that in MS there are genetic factors. And so our current theory about MS is that there are genetic factors on the left-hand side, and something else triggers off in a susceptible person who maybe is genetically susceptible, something else triggers off the MS. And on the right-hand side, you can see some of the things that we think could be triggers. So firstly, there are geographic factors. We know that MS is much common in people that are born in northern latitudes. That would be Northern America or Northern Europe. In northern latitudes, MS is much more common. And if you go to equatorial regions, MS is hardly ever seen. So there's definitely geographical factors. And then how about microbial agents, bacteria or viruses and things like that, that probably are a trigger in some people? There's probably many of those that may trigger off MS. The one we definitely know about is Epstein-Barr virus. So people that are genetically susceptible and are then exposed to Epstein-Barr virus, that may trigger off their MS risk. And then vitamin D, becoming more and more of an important factor as a risk factor. And smoking and obesity, the bottom 2 points over there, are risk factors. So what we're trying to do with MS over time is to treat MS and look at MS the same way we would if you had high blood pressure or diabetes or some metabolic disease. When you see your physician, they're going to say to you, well, okay, you have this condition, you need to have a healthy diet and avoid salt and eat and avoid sugar and lose weight and things like this. They're trying to tell you for general health. Well, look at these for MS. We're trying to get to avoiding risk factors. So if you have MS and somebody in your family has susceptibility, what can we tell them? We can tell them, take vitamin D. So just like you should be taking vitamin D, so should your family members who may be susceptible take vitamin D. And they should not smoke. And obesity seems to be an important risk factor that is now being evaluated in adolescents and young adults. If you have MS and you have an adolescent child or sibling or young adult and they are overweight, this seems to be another risk factor. So there's 3 risk factors we can tell someone now. Don't smoke, take vitamin D, and watch the diet. These are all important factors. So these are some of the things that we're beginning to understand about MS and trying to put some preventive factors into place. This just shows you some of the steps that happen with MS. And so the first step that I told you about is that you have a susceptible individual and something triggers off the immune system. And the important cells in the immune system that everyone seems to know about are the B cells and the T cells. They are lymphocytes. They are a kind of white blood cell. And when the trigger stimulates them, these cells are activated, and the target is the brain and the spinal cord and the optic nerves. The target of the immune attack in MS is the central nervous system. The immune attack could target anywhere in your body. It could target your joints, then you would have rheumatoid arthritis. Or it could target your thyroid gland. You might have Graves' disease or Hashimoto's disease. But in the case of MS, the target of the attack is the central nervous system, brain, optic nerve, and spinal cord. And so there's inflammation in these structures, and that's what leads to all the symptoms. It leads firstly to demyelination, and eventually the nerve fiber can be damaged, and you can see some atrophy in the brain. And so these are the different steps. And so that's why we want to treat early. We want to treat early before we go through this whole series of steps. Because once you have atrophy or a loss of the nerve cell called the axon, there is no recovery from that. That is permanent damage. Early on when there's inflammation, we can stop inflammation and we can try and stop demyelination. There could even be a little bit of remyelination. But there can be no recovery once the nerve itself is damaged. Once the axon is damaged, there can be no further recovery. So we want to act early to stop this sequence. I left this slide up over here to show you what inflammation looks like. So if you look on the outside of the slide, that's normal brain tissue. And all the purple bluish cells around that the red structure in the middle is a blood vessel, and all the millions of blue cells around it represents inflammation. So you can see on this picture the difference between what inflammation looks like and what an area that's not inflamed looks like. And that inflammation is going to leave a scar if it's not treated. It has a potential for leaving a scar. And so the land of MS, you know this slide, I put the slide up every time, but it's just what we could talk about at any meeting. We could talk about any of these things when you're in the land of MS. They're all topics, each one of them we could spend a week talking about how do we diagnose MS and how we treat MS, how do we treat the relapse, how do we treat the disease. And then the symptom tower. In this land, we have a big tower because there are so many symptoms. We could spend all day talking about the symptoms. And what kind of medical support do you need? Ophthalmology, psychology, urology, psychiatry, physical therapy, all the therapy, medical support, social support, being part of a support group, being part of groups like this. And finally, and most important at the bottom there, self-help. What you do for yourself, very important. So in some ways, if I could think of this more creatively, I could make this into, maybe I would make self-help into part of the foundation, because it is part of the foundation of everything that we do. Now we talk about the symptoms of MS. So you've seen different ways that we've talked about the symptoms of MS in the past. And I want you to think about this way of thinking of the symptoms when you describe them. When you go to the neurologist and describe your symptoms, you could think about them this way. My symptoms are stable. There's no change since last time. Or they're constant. Or they could be stable and constant. My symptoms haven't changed and they're constant. They're stable and they're constant. And they fluctuate. Could they be all 3 of those things? Yeah, they could be. Your symptoms could be the same set of symptoms you've had before. They're there all the time to some degree, but they're good and bad days. So your symptoms could have all of those things attached to them. Or they could be new. Now we're starting to think about, do you have a relapse? Or they could be progressive. Now we're starting to think about, what kind of MS do you have? Could this be a progressive type of MS? So all these kind of adjectives over here are helping us try and define how your MS is doing and what kind of course your MS is taking. And then we have this classical way of thinking about the types of MS. And you can see right in the middle there, the commonest type of MS you all know about is relapsing and remitting MS, which affects 80% of people, approximately 85% of people to start with. And there is that little arrow circling back there, because if you don't treat relapsing and remitting MS, we know what happens. It can become progressive and develop into secondary progressive MS. And some people will start out with progressive MS right from the onset. That is called primary progressive MS. And then on the top part of the slide, you'll see what we call a radiologically isolated syndrome. And that is when someone is discovered to have an MS-like scan. The MRI scan looks like they have MS, but they have no signs or no symptoms of MS. It's a coincidental discovery. And finally, what's referred to there as the clinically isolated syndrome, which basically is probably going to be renamed into the first MS type of event. So we can see MS early on, we can see MS with relapses, and we can see MS with progression. There are different stages of MS that can occur. And this defines a relapse for you over here. It's very important to define what a relapse is, because a relapse could be a new symptom, or it could be something that you already have and it gets worse. But it must last for at least 24 hours. So if the symptom only lasts for 15 or 30 minutes, that's not a relapse. A relapse must last for 24 hours. 15 or 30 minutes, not a relapse. And depending on the age group of the patient, we might have other concerns. If an older MS patient has numbness or tingling that lasts for 30 minutes, I might be worried about a stroke or a warning of a stroke rather than an MS type of symptom. And the other important thing about a relapse, not only must it last 24 hours, but there must be no other explanation for it. So are people with MS heat sensitive? Yes. Somebody's Apple phone is making a noise. So important to rule out other causes. You have fever, you have an infection, urinary tract infection, upper respiratory tract infection, you have high fever, you feel weaker. It's not a relapse. It could be just a pseudo-relapse. You feel much worse. We treat the infection, we treat the fever, and you feel better. So it's very important to define, make sure that there's nothing else that's causing the infection, that's causing the symptoms. And the other thing is that you could be on a new medication, for example. How about you just started a new medication for your bladder, and it made you feel dizzy, or fatigued, or lightheaded, or some other symptom. So we always have to make sure when you have a relapse that there's nothing else that's causing the symptoms before we want to actually treat the relapse. So, okay. So this just lists some of the symptoms of MS. We're not going to spend time talking about them, but of course there's a long list of them that you can see over here, because any part of the central nervous system or the spinal cord or the optic nerves could be involved in any one of these symptoms. We could go into discussion. The important thing about these symptoms, if you think about it, and we'll talk briefly about that, is each one of these has something we could do for it, which can result in some problems, and we'll discuss that in a few minutes. And then never forget the invisible symptoms of MS: fatigue, pain, and cognitive problems. And remember that the largest cause of disability in a young person, the biggest reason why a young person is disabled from the workplace and becomes unemployed is because of these invisible symptoms: cognitive problems and fatigue. So there is no way for compensating. Very difficult if you have a position that requires a lot of cognitive process and you can't remember and you can't think. You can't replace that. If you can't walk, you can replace that. You can get a wheelchair, you can get a walker, you get to work, you can work. But if your cognitive processes are damaged, you cannot replace that major cause of disability. Let's talk about what happens if you don't treat people. So about 10 to 20% of people have benign MS. And by benign MS, we mean that someone's had MS for at least 20 years and they have minimal disability. You don't know that at the beginning. You know that when you followed someone for 10 years. About 5% of people have malignant MS. That is the most severe form of MS, where they rapidly become disabled. But in between that is the majority of people. And we know that about 15 years after the diagnosis, 50% of people have progressed. And at 25 years after the diagnosis, 80% of people have progressed. So that's what happened without treatment. These studies were done before there was treatment available for MS. that at 15 years, 50% of people progressed. And now with our medications, we feel we're able to slow down some of this progression. And clearly the goals of our treatment: reduce the relapse, the frequency of relapses, slow down the progression of disability, improve the MRI outcomes, reduce the morbidity from the symptoms, make sure that people adhere to their medications, make them comfortable and understand, and then try and give you medications that we understand and can monitor the long-term efficacy and safety. And the important thing about this slide, the most exciting slide really, for some people, and I'm sure there are some people sitting here that have had MS for more than 20 years. And 20 years ago, or 22 years ago, the first drug for MS was approved. And if you look on the left-hand side over here, you see beta-seron that was approved in 1993. That was the first drug. Before 1993, we had no drugs approved for MS, and we now have 12 approved drugs. So we have some options to treat relapsing forms of MS, and other drugs that are in clinical trials that might be approved soon. Very soon, this whole thing will be full. We might have 14, 15 drugs approved for MS, for relapsing forms of MS. So unfortunately, for progressive forms of MS, we're still quite restricted. We have no drugs still that are FDA approved for primary progressive MS. And for secondary progressive MS, sometimes we use chemotherapy drugs. It's the only FDA approved kind of drug. So the progressive forms of MS were still, unfortunately, quite far behind. I just threw in some research drugs here. Again, you can look them up on the YouTube version when this comes up. But this is showing you some drugs that are in research. It talks about stem cells that are being researched and some common medications that are being researched. What's the importance, for example, of vitamin D? How does it work for MS? And what about statins and common substances, antibiotics like tetracyclines and minocycline are being studied for MS? These are all exciting things that are being studied. It's hard to get some of these studied because they're approved drugs. And who pays for these kind of studies? And this talks over here about this slide is, how do you know what drug to start with? If you're on a drug and it's not working, how do you know how to switch? And I would point out to you the three first items over here are most important: safety, efficacy, and tolerability. So when you want to start a new medication, you need to have the conversation with your neurologist and say, if I'm picking a drug, we need to talk about the safety of the drug, the efficacy of it or its effectiveness, and its tolerability. Those are three very important points that you want to talk about. And then you might want to know about how it works, because depending on that, if the drug doesn't work and you have to switch off the drug, do you need a washout? How does it affect the immune system? If I stop taking it, does my disease rebound? And finally, at the bottom, is cost and convenience. So we could be talking about all this stuff. Pick a drug for you that you like the safety of it, you like the efficacy, the tolerability seems reasonable. Doesn't matter what we think. Some insurance company will come along and talk to us about, well, you can't have this for various reasons. You have to try something else first. So there's still fighting going on between us and them, because we feel we're doing the best, picking the best drug to go with our patient. An insurance company doesn't think about that. They think, and I think about the shareholder and God knows what other reasons they could be thinking about. So this is an important set of things to talk about when you go for that office visit. At the end of it, if we're talking about the disease-modifying drugs, this is important things, important points, always. So if you're starting a drug or switching to another drug, you always have to think about these points. And this slide will also be on YouTube. This slide actually is a different version of the last slide. It tells you all the things that come into play when we think about starting a drug for you. If we're thinking of starting a drug for you or switching to another drug, these are all the things that come into play. Safety, efficacy, tolerability. How do we monitor this medication? How convenient is it? What's the cost? What are the pregnancy issues? How does it work? What's your preference? What's your doctor's preference? There are a whole bunch of things. Just picking a drug is not just like a random thing. It's a complicated process, and which is why I put this slide in, and so you could see all the things we have to think about. Now, the only important thing about this slide, I don't expect you to look at anything, except all you see on this slide is that there is a long list on the left-hand side of the MS symptom, and on the right-hand side is all the medications you could be taking. And so think about that for MS. And we talked about, that's why I showed you the symptoms earlier on. You could have a lot of symptoms. And if you have a lot of symptoms and you want treatment for all of them, you could be on a lot of medications. And do you think that leads to some potential for interaction? That's what the importance of this slide is. If you want something for fatigue and depression and spasticity and pain and a bladder problem and a bowel problem and a cognitive issue and a tremor, all these they have medications. And so we've got to watch out always and be wary for interactions. And so that interaction of many drugs is called polypharmacy and the risk of interactions. And think about what I've just shown you. That's all the things we could do with your MS. How about someone may have another chronic disease? Diabetes, much more common disease. You could have diabetes, heart disease, hypertension, other diseases, and you take other medications, and now you're looking at multiple prescribers, and so interactions always have to be wary of interactions. Drug formularies change, the number of medications has increased and escalated considerably, and then you might need a different dose. Some people are more sensitive to a certain dose, so they might have a dose that may be not the right dose for them. All these adjustments have to be made, so we constantly have to think about this risk of interactions. That was the introduction that I wanted to give you, talking about our considerations of the medications, how to start a drug, how to switch a drug, all these important points about what kind of MS you have. These are all the points that go into your thinking before you come for your visit. So before you come for your visit, you think about all these things, and ideally, before you come to your visit, you have filled in the paperwork already. So we set your visit for 9 a.m., and you arrive at 9 a.m., we're already behind. So think about this now. You're behind, I'm behind, and every other patient for the rest of the day is behind because your visit's at 9 a.m. and you only came 9 a.m. So please, when you have a visit at 9 a.m., come early. Fill in the paperwork. You know there's paperwork. There's all kinds of nonsense to fill in, but you have to do it. It's our modern age. We have no choice. You have to fill in the paperwork. So come early and fill it in. Or better yet, what I'm about to show you is on the internet. Go there to MS Views and News page and look for the communication tool. Fill it in the day before or 2 days before. So when you come to the office, all this information is available. Because how many visits do you have a year? Hopefully you're very stable and you might only have 1 or 2 a year. It's a valuable time. It's a time to go over all your concerns. Write them down, make notes of them, your questions, all the information, your medications, everything. This is in front of you. So don't worry if you can't see that because everybody has this. Does everybody have this sheet in front of them? The communication tool. Do everybody have this? Do they have this? Everybody should have this. You all have this? This is the communication tool. This is what you can find on the MS Views and News page, and this is what you can print out the day before, so you save time. If you've done this the day before, this gives you time to sit and look at these things and say the basic stuff on top. We always need that basic information. Put in the name of your pharmacy. So if we have to call in a prescription for you, we have it on file. We know what your new pharmacy is, or if your insurance has changed. So that doesn't cause delays when we have to do things for you. And then most importantly, this lists the symptoms. So we're going to want you to list symptoms that you have. List all your symptoms over here. Circle them, make notes, whatever you need to do. And then it asks you above that, why are you here today? What is the reason for your visit? It could be straightforward. It's an annual visit. I need a refill, or I have a new symptom. I have new symptoms, or I think I'm having a side effect from my medication. There is place for you to write that. If you write that and you hand that to me or to your neurologist, very quickly I know what our visit is going to be. We can plan the visit. It can be a valuable visit. Instead of forgetting something by not writing it down or not filling in this form. And so I've said this before. You've all heard me say this before. I don't apologize for doing the next little piece again, but I'm going to do it again. It's much better if you do all this than if we have to deal with the door question. So do you all know, I've spoken about this before, do you all know what the door question is? Who knows what the door question is? Somebody must know. No? That's good. Well, there's no door here for me to demonstrate it to you. The door question is that we've spent 30 minutes or 40 minutes or some time together and you're about to leave and you're standing at the door and you say, oh, I forgot to ask you about this. Of course, this is never straightforward. It's not like who's going to win the Super Bowl, because I could answer that for you in a second. That's not the question. The question is, I forgot to tell you I'm having bladder problems. Well, guess what? Bladder problems and MS are a big problem, and they're not simple. You can't talk about them in 1 second. So write the questions down so we don't have to have a door symptom. So we've got, oh, please turn your phone onto vibration. Well, yeah. Not very good, is it? Thanks for calling. There you are. Who's called me? Did one of you call me? Somebody call me to test? Okay. So that's the door question. Write everything down so your visit is more valuable. And then underneath that, list all medications and supplements. And it says there, and supplements. I want to know what you're taking. Are you taking vitamin D and B12 and CoQ10? What are you taking? And let's look at all your drugs. Let's make sure there's no interactions. It's an important section. If you don't want to write them down, have a written copy or a computer printout, some copy. And so the next piece I've spoken about before again. People will write there, what do they write? Same. Yes. Or unchanged. So please will someone tell me where I can get same? Where do you get same? Okay? I went to the pharmacy and I said, can I get same? And what did they say? We don't have it. And I said, do you have unchanged? I said, a lot of my patients are taking unchanged. It seems to be great. Half of them are taking unchanged. Don't have it, sorry. Write it down. We need to look at it, because guess what? Half the time when you look at that, there is a change. There is something different. So write down your medications. Tell us your medications. If you know the date of your last lab work, tell us that. Help us make us, it's much easier if we have your lab work, so we don't have to call somebody, your primary care doctor, and get the prescriptions. If you know the dates of your MRI and your lab work, all that stuff is very interesting. If you have injection reactions, all those questions are asked over here. So that's page 1 of this communication tool, which is going to help your visit a lot. And page 2 of the communication tool starts out on top there with some social facts. For example, are you still working? Let us know about that. It could have changed from last time. Do you smoke? That's a question. Other questions. Have you tried to quit? What about alcohol? What about caffeine? What about exercise? Those are all very important questions. And then some psychological questions over here. How much stress do you have from a level of 1 to 5? Do you need help getting community resources? What is the quality of your life? And this can help us help you. We might have to refer you for help, for counseling, to see a social worker, for some community resources. You just heard talk from Stuart and Jennifer about a social network, a social navigator. And if you call and get help from social services about how to find community resources, could be transportation, could be other things. So to get that help, we know about this if you need that. And then underneath that is the review of symptoms. And this refers, some of these apply to MS, such as your bladder and your bowel. And a lot of these apply to other conditions. It's very important for us to know that too. It may impact the medication we're going to prescribe for you. Heart conditions, lung conditions, endocrine conditions. Are you diabetic? A whole bunch of different things. And you have it all in front of you, but these are 2 pages over here. I don't know how to show these up any better on here, but they're all recorded, which is why we don't have to make them any larger than this. But this asks you about a whole variety of other symptoms that are very important. Some of them are related to MS, some are not, but it's part of our comprehensive history. And if you fill this all in the day before, there's no stress for you. I can look at all the symptoms, and we can try and help you manage them. And then I'm going to do the final section over here about this very important part over here is self-help. That's the first acronym. If anybody ever has a better acronym, I'd be very happy to see it, if we can, because this is the main acronym that I have now, this one, which is Team of Friends, which really is all the things that you need to be thinking about and doing. And this is not in any order, it's just a way of putting this into words, because certainly temperature management is important, but it's probably not the most important thing on the slide. But that's what the T stands for, is temperature management. How many people are heat sensitive? Somebody even told me today, just going from a restaurant to their vehicle, just like 2 minutes is enough to wipe them out. Just a very short distance. I said, get a cooling vest. So there are things you can do for temperature management. And then the expectations are very important. That you understand any medication that you take, that you understand the progress of MS, that you understand what kind of disease this is, and you understand the effects of medications and their side effects, and what our goals are when we give you medications. So expectations are very important. And then adherence. Adherence means taking your medication. In the old days, we used to call this word compliance, but they changed it. They said compliance is, in this modern, politically correct age, we can't say if you take your medication or don't take it, that you're complying. Because they said complying sounds like one-sided, like we're giving you an order and you're not doing it, so you're not complying. In my eyes, that's nonsense. We're part of a team. And complying or adherence is all the same thing. Take your medication. I'm giving you a medication for your good. If you don't take it, it's no good to me. It is good to me, actually. I guess you get sick and you come see me more often. But I don't want that. I get happier if I see you doing well. Believe me, I'm happier when you're doing well. So adherence to your medication is very important. A lot of people think, I'm doing great, I don't have to take it as much. And guess what? You have a relapse. Mental aspects. It's a huge topic, and that includes all kinds of aspects of mood changes in MS, anxiety, depression, and then the memory aspects and the cognitive things, and then sleep. Now, do you see how all these things are starting to interact with each other? Guess what? If you don't sleep well, you feel more exhausted, you might have other symptoms coming on. Outlook, a positive outlook, always a good thing. Where is Stuart? Is Stuart here? No, he's disappeared. Fatigue management. How do we manage fatigue with certain medications? But other things, we need to look at why are you fatigued? It's complicated. We'll talk about some of those in a minute. And then diet, food, the dietary intake. And that's controversial. But you know there are many different diets out there. If you went on the internet, you'd find all kinds of different diets. Somebody today asked me about the McDougall diet. How many people here know about the McDougall diet? McDougall, we've got a couple. McDougall diet is basically a vegan MS diet, which is published. Look it up on the internet. They did it on MS, a group of MS patients, the McDougall diet. And then there's Terry Wall's diet. How many people know about Terry Wall's diet? At least a couple too. So that's a diet where Terry Walls, who is a physician, was in a wheelchair and did this particular diet and claimed that after eating this particular diet, she recovered and became a functional person again. That diet, you know, everybody's got their own diet. That diet is a diet in which she does have a good amount of vegetables, but that diet also includes eating organ meat. So if you like kidney and pancreas and kidney and organs like that, you can look at Terry Wall's diet. And then there's the Gold Coast diet, and then there's Dr. Swank's diet. There's a lot of different diets. You look at the diets and read them and think what you like for yourself. Relationships, interactions, a group like this. Exercise, I can't tell you how important exercise is for all these things. Exercise is important for physical and mental well-being. Keeping up with the news. Vitamin D, I gave its own kind of word here because maybe I couldn't think of something else to put there, or because it's so important. And smoking, the importance of not smoking, or we spoke about before. And there's probably some other things but these are all things that you have some control over. So they're all very important things to deal with. And then we'll talk a little bit about nutrition, what I called defensive nutrition, which means eating breakfast. Your brain needs glucose to work. So if you don't eat breakfast, your brain is not getting glucose. Where's it coming from? So it's very important to have breakfast and to eat meals. And you know it's better to eat a smaller meal more frequently than large meals. Fat in the diet. Dr. Swank is the original MS diet. When Dr. Swank published his diet over 50 years ago, he said that people with MS shouldn't eat saturated fats. Now, I'm not saying your diet should be fat-free by any means, because myelin is made of fat. You have to have fat in your diet. I'm just saying your diet should emphasize unsaturated fats. So have fats, but have unsaturated fats. And plants and fiber and fluids and supplements. These are all important things in the diet. And the plants, some of you watch PBS. How many of you have seen Joel Fuhrman's piece on PBS? You probably have all seen it somewhere along the way, but you should watch it if you ever see PBS and Joel Fuhrman, and that's what he talks about, eating all these plants. Colored vegetables, onions, mushrooms, berries and beans, and seeds. All very important. And he's got a great, and he's published books, but all that stuff is great. Vitamin D we spoke about, we won't go to much more, except that vitamin D is widespread in the body and very important for MS. And if you want to know what the level is, and you ask me how much you should take, of course I can't tell you. You should go and get your blood level checked. When you have your blood level checked, then I can tell you what your level should be. It should be 75. And now they've done studies where they've looked at people with MS. They did a study in Boston, and they compared people with a level above 50 to a level below 25. And guess who progressed more rapidly? People below 25 progressed twice as much as people above 50. More rapid progression. And they've looked at vitamin D in other ways as well. Is that if you have, not only with the progression, but if you have early MS at the beginning, there's a higher risk of developing more definite symptoms if your vitamin D level is low. So vitamin D is a very important prognostic factor. Salt, I'll just briefly mention salt. Again, it's all going to be there for you to look at on YouTube, but it's shown in one study that salt intake also correlates with MS progression. And so they looked at people and the amount of salt that they ate compared to, and you can't measure the sodium in the blood. That doesn't give you this indication. It's the amount of salt in the diet and what's excreted. So salt is another very important factor in your diet. Avoid salt. Try not to cook with salt. Use other seasoning, and don't add salt. And then this section that I call defensive dining, which is not only should you control the content of what you eat, but also the amount of calories. Watch what you eat. And so share portions. I've said this before. And who do I always say you need to share with? Share with? With who? Yourself. Share with yourself. So when they bring food, and I don't know what size portions you're going to get, but when they bring the food, almost always too much, unless it's expensive, of course. If you go to some fancy restaurant where it's like, like $27 for a tiny piece that size, eat it yourself. But typically when you go to an average restaurant, you order something, it's a massive plate of something. So the first thing you do is ask the serving person to bring you something to put it in and say, I'm taking half of this home. Divide it in half and take half of it home. Share with yourself. Take half of it, immediately put it in the box. Don't even think about it. Just put it in there and then take the rest of it and spread it out on your plate. And I guarantee you'll have enough to eat there. Almost always. Share with yourself. You get 2 meals out of it. So sharing the portion. Eat slower. Now, part of eating slower is that when you put food in your stomach, if you're hungry, as you put food in your stomach sends a message back to your brain. It takes a while for the message to get there. It takes a while for the message to get there. So if you eat slowly, the brain is starting to get the message and you don't have to put as much in. If you swallow it all quickly, the brain has hardly got the message. You keep pouring food in. That's why eating slower. And put the salad dressing on the side and make sure it's low-fat dressing. And alcohol has calories, a lot of calories. If you drink a couple of beers every night, it's a lot of, just add that up at the end of the week. And salt and sugar, and sugar, of course, we all know is poisonous and saturated fats. There's no doubt that sugar is a very bad substance, so avoid sugar. Here's a good illusion for you to look at. This is what they do in a restaurant, right? You can look at these 2 plates. Guess how much food is on each plate? Identical. Guess which one people are going to say, oh, boy, I'm hardly eating anything. I'll have some more. My plate's empty. Give me some more. It's an illusion. And there's many others like this. I just threw one in here, but there's many others like this. So even that big one, even that one on the right, split it in half. We spoke about this obesity and genetic susceptibility. I'm not going to go over that again because we don't have long. These are some of I put this in again, you will find this. These are some of the references that I thought were very good. The Swank Diet, a book called The Blue Zone, which talks about areas of the world. He was commissioned, the author of this book, to go by National Geographic to some areas of the world where people live the longest. And he wrote this book about 4 areas of the world where people live long and related it to their diet. The China study and some different things that you can look at over here. In the interest of fairness, I put in there Grain Brain and Brain Maker by Perlmutter. Anybody know Dr. Perlmutter? Anybody has seen Dr. Perlmutter? 1, 2 maybe. Dr. Perlmutter is a neurologist, or was a neurologist that he retired on the West Coast and in Naples. And he was a neurologist who found this thing about diet and promoting dietary things. And he wrote these 2 books. And his books are about different kind of diet. He talks about a gluten-free diet. In his diet, you're able to eat some meat and some animal products occasionally. So in the interest of full disclosure, I put those in as well. And this over here is about, you see the title of this, if you can see it there, Gut Reaction to MS. How important is the gastrointestinal tract? It's becoming more and more important. What you put in your body, so the interior of your body is called the microbiome. A biome is a large geographical agricultural area that has specific plants and animals in it. And the microbiome is what's inside your gastrointestinal tract, in your intestines, in your stomach, the bacteria that grow there, and there are trillions of them, or billions of them. And there are certain ones that are good and certain ones that are bad. And there are some that are anti-inflammatory and some that are pro-inflammatory. That's why more and more people are thinking this is important. And the very top of this slide, I wrote there, the gut. This was a lecture by Dr. Howard Weiner. Some of you might know him. Dr. Howard Weiner is at Boston, probably one of the best MS researchers internationally. And he presented this paper on the gut, the next frontier in MS therapy. How important it might be to start for us to pay attention to what we put into our gastrointestinal tract. For example, they've done studies. If you go to third world countries where people have parasites, guess how much MS they have there? Very little. Now guess what people did? Oh, these people have parasites. Let's get rid of their parasites. We'll make them better. Guess what disease we're seeing in these countries now? Exactly. And other autoimmune diseases. So these bacteria and parasites were living in the gastrointestinal tract doing some good. That's the parasite story. We're just winding down now. Social support of all kinds. Management of fatigue. Remember, there are 2 kinds of fatigue. There is, and we'll talk about that in a second, but I want to point out the bottom that I put in over here is that fatigue is not laziness. Because how many people here are lazy? I'm sure most of you have been told at some point you're lazy. or you lack motivation. How many of you lack motivation, or you're psychological? You could try harder, and it's nothing like that. It's MS fatigue, and we divide fatigue into two kinds, and it's very important that we determine which kind you have. And you have primary MS fatigue, which is the fatigue you have just because you have MS. But it's important for us to rule out secondary fatigue, which is that you could have fatigue for some other reason. You could be weak, you're not exercising, you're deconditioned, you're not sleeping well. Why are you not sleeping well? Because you're depressed maybe? Or why are you not sleeping well? Because your bladder wakes you up 7 times at night? Or you're heat sensitive? Or medication side effects? Or other medical conditions? It's very important for us to look at this and say, do you have primary or secondary MS fatigue? Because if I just give you Provigil because I think you have primary MS fatigue and you've got one of the other treatable things, I haven't done you a service. I need to say, is it a sleep problem? Is it your bladder? Is it something else? These are some of the medications, for fatigue. We use some stimulants. I listed them over there. Exercise is very important. We won't do much about that. Jeff is going to tell you much more about exercise later. The importance of exercise, part of being motivated, enjoying the exercise, making it part of your routine. Smoking, we're not going to go into. And it's my final slide over here, which is what I call the pillars of MS. The things that summarizing some of the things that I want you to do, which is taking vitamin D, paying attention to your diet, low salt, low sugar, avoiding saturated fats, avoiding smoking, exercising regularly, support in and support out. So getting support, very important. And the better that someone's support structure is, there's no doubt the better they do. Also, you can do things, though. Support out. What do you do? So understanding interactions with other people, understanding that when you're out there, and this applies sometimes to people that may be walking a little slower or need a cane or some other slow means of getting around, you want people to have a little bit of compassion and patience and kindness. And so similarly, you need to do those both ways. And so I think of this finally as what I call my bucket list. Everybody has a bucket list of things to do, right? We all have that. Bucket list of things to do. I want the Dolphins to win the Super Bowl. Actually, it's not in my power. How about a bucket list of things not to do sometimes? Not to be impatient. If you're in traffic and somebody puts out their turn signal to turn in front of you, what does that mean? Speed up? Is that what it means? No. Slow down, let them in. So a bucket list of things of compassion, patience, kindness, and things like that. So, and with that, I'm done. Thank you.
Thank you, Dr. Steingo. So now, what I didn't get to tell you all before, because I didn't expect you to be eating right now, is that we're going to go around the room. I'm going to go on this side with a microphone. Jennifer is going to be on the other side, and we're going to go from table to table and see who has questions. Please remember that the cameras are facing that way. They're not on any of you. We'll hear your voice. If you don't want your voice recognized, speak in another tone, okay? You live in this great state. I say that too often, though. But great state of Mickey Mouse. You could sound like Mickey if you want, or Minnie, whichever the case may be. Anybody have a question over here? Right there. Okay, I'll get Tom. Oops, sorry. Rule that out.
How long does it take for the brain to know when the stomach is filled? So, how long till you know you're full? Your brain, like in the amount of minutes? It's how long?
No, it's okay. So, well, I guess you got the mics. Everybody heard that. So his question is, how long does it take for the brain to know your stomach is full? So, I mean, that's very variable, Tom, is the answer to that. So firstly, it depends on how hungry you are to start with. That's one thing it depends on. The second thing that it depends on is what kind of food you have. So some foods will give you a full feeding much sooner than other foods. So for example, if you have a meal and you drink a lot of water with it, your stomach might be a little fuller, and you might, for example, you'd eat food, and you might actually eat a little less if you have some water at the same time, if you modify it in that way. So the answer is it depends on the kind of food, and it depends on how hungry you are to start with. That's the two things that it will depend on. It's certainly more than a minute.
Anybody have questions over here? If you know all the answers, what are you doing here tonight?
I got one over here. Here you go, sir.
Oh, how do you differentiate between an MS relapse and a pseudo relapse?
Well, not always easy. because for the following reasons. So firstly, a pseudo-relapse would mean somebody that had an infection. You had a urinary tract infection or an upper respiratory infection, you had high fever, you felt very weak, the temperature subsides, and you start to feel much better right away. Then that would probably be a pseudo-relapse. On the other hand, an infection can actually bring about a true MS relapse. So in that situation, someone would have a fever, the fever starts to subside, but they feel no better. They've treated the infection, and they feel no better. In fact, they might even feel worse. So an infection can bring about a true relapse as well. So only over time you can tell that. So if you have a potential relapse, and you say, I think I'm having a relapse, and you have infection symptoms that just started, I might not want to start steroid right now. Let's wait a day or two before we start steroid. It's not an emergency to start steroid immediately. It's more important to make sure we're giving it to you for the right reason, that you're having a relapse and that there's not something else going on. So it's not always easy is the answer to that question. Sometimes a little bit of time.
Dr. Steingo, I was wondering what was the latest research with respect to the PML numbers to keep people, I know this might be off topic, but I was a Tysabri patient before, and I'm wondering what has the research been suggesting as to what those numbers really mean and what they're translated to as far as your decision to maybe restore someone to Tysabri who's been off it?
The answer to the PML question is that there's nothing new about that. Essentially, if you take Tysabri, we know that there are three things that give you a risk for PML. The first thing is the duration. The longer you take it, the higher the risk. The second thing is JC virus. If your JC virus is positive, you have a risk. And the third thing is prior chemotherapy use. So pretty much these days, if someone's had prior chemotherapy, we would not use it. But the other two factors, the length of use and the JC virus antibody, are risks. And so the longer you've been on it and the higher the antibody, the higher the virus index, those are two risks. We're looking for other ways of predicting it. But right now, that's the only things we have right now. There's nothing newer than that still to this day.
Another question going forward with that is that for a person that came off of Tysabri because they turned from negative to positive with JC, and their doctor took them off of the Tysabri, maybe just because the doctor felt insecure about staying on, is there a reason why the patient cannot return to taking Tysabri?
Why they cannot return? No, if they decided. So in other words, when you're on Tysabri and you have been on it for a long time and your index is high, you have a certain risk. So we have a table, an index table that we can approximate. We can give you a guide to your risk. We can't tell you exactly what your risk is. We can give you a guide to the risk. And we can look at that and tell you. So if you decide, if your MS is not doing well, and you decide you want to go back on Tysabri because it was the best drug, then you are accepting, saying, I know there's benefit, I'm accepting some risk for this benefit. So that's what we would look at, the table, and say what the risk, the benefit is. Now, if you go back on Tysabri, in most cases, it doesn't change your risk. If you've been off Tysabri for a while and you go back on it, there is a risk of an infusion reaction. Other than that, the risks are exactly the same.
I have a question here. Fatigue. Even with exercising, when that fatigue comes over you, just can't move. Is it a nutritional thing? Is it something to discuss with a nutritionist as far as what I should eat next, like right after exercise maybe? Or is it vitamins? Anything additional other than like a Provigil or a pill? I don't want another pill.
Yeah, so the answer to that is, like I showed you on the list, there's many other things that can contribute to fatigue, including what we call weakness and including deconditioning. Somebody's just out of condition. And deconditioning could be a physical thing. It could be a nutritional thing. It might be something you notice. You might notice that after certain meals you feel stronger than others, or you feel weaker than others, or if you exercise and you haven't eaten properly. So there's no harm always to see a nutritionist and make sure you're getting the right foods. But exercise is very important. There's no doubt that if people don't exercise, they become deconditioned, they lack endurance, they get more fatigued. It's just a vicious cycle. It sets up one thing after another. So it's a combination of things. I think you need to try and look at the individual items and say, maybe I'm not eating well. Do I need to see a nutritionist? Am I doing enough exercise? Should I see somebody about exercise? Just do them all. I think you look at every single step. There's no way of picking exactly which one it is. If your vitamin D level is good and your B12 level is good, then it's not those things. Then it's something else.
What about B12? Is that something that is recommended?
Yeah. So
is the B12?
The question is, what about B12? B12 is not important for MS specifically. But B12 deficiency is important for the nervous system as a whole. If your B12 is deficient, it can affect the entire nervous system, of which MS is a part of the nervous system dysfunction, of course. So, yeah, we should check B12 like we check the vitamin D, check B12 as well. B12 deficiency certainly can make you weak. On the other hand, if your B12 level is normal, taking B12 shots is a waste of time. So you do check your B12 level just like you check the D level.
I have a couple of questions. As far as your D level, by taking supplements that will elevate your D in your blood, supplements will do that?
Can you repeat that question?
Okay. All right, never mind. I have another question. I have constant nausea, and I was wondering if our gastrointestinal tract is affected by MS.
Sure it is.
And
So she has constant nausea?
constant.
Yes, so there's many causes for that people with MS can feel nauseous. One thing is the drugs. Sometimes medications can do that. If you've changed medications, you always have to look at your medications. The other thing is that, yes, MS can affect the gastrointestinal tract. It can slow the gastrointestinal tract, just like it can slow down your bladder or your rectum, and you can be constipated, your bowel doesn't empty, and so MS similarly can affect the stomach. The stomach might not empty properly. Food will sit in the stomach. People can feel nauseous. They can vomit. And definitely MS can affect the gastrointestinal tract. And if you have chronic nausea, you need to see a gastroenterologist. They need to evaluate your stomach to make sure you don't have slowness of emptying of the stomach. It's called gastroparesis. You need to have that evaluated.
One other question. If you have a constant bladder infection, can that increase spasticity? And if you can't treat the bladder infection, and so basically, does it just...
Yeah, I mean, if you have constant infections, oftentimes there's fever. We know that fever makes people feel weaker, and it can certainly increase spasticity. So the answer to that, yes, it potentially could increase spasticity, would be the answer.
I heard that if you stop taking Tysabri and then you go back on it, you don't have the same outcome as you did from prior use. Is that accurate?
No. Well, it depends how long you stay away from it. So if you take Tysabri and you stayed off for several years, not if you go if you go back within a few months, your risk is identical. Tysabri can be detected for up to 6 months. So the risks of PML with Tysabri can last for at least 6 months. If you stop Tysabri, there is still risks for PML for at least up to 6 months. But if you go off Tysabri and you've been off Tysabri for several years, potentially you may be resetting and starting out again at a new level. But remember, if one of the reasons you stopped was because your JC virus is very high, when you go back on it 5 years later, it's still very high. So you still have somewhat of a risk.
No, what I meant was when you stop taking it and then you go back on it, then your body doesn't have the same reaction as it did the first time you were on it?
You mean it doesn't work as well?
Yes.
No, that's variable. If you went off it, it depends why you went off it in the first place. But no, that's not true. If it worked very well for you, but you stopped because of some other reason, you go back on it, it may be equally effective.
Oh, okay.
So no, I wouldn't say that holds. Unless you stopped it because it didn't work.
Question: if you have been taking Avonex for a long time, and then decide that you're just going to stop taking it, what are the chances of you getting an exacerbation or a backflash of the drug of the disease?
So if you stop any medication, the one medication we know for sure that if you stop Tysabri, within about 2 months to 3 months, there's a high risk of a relapse. And so the same thing that applies to your Avonex. If you've been taking Avonex for a long time and you stop taking it, I can't tell you that. It's very variable. It depends what the Avonex was doing. If the Avonex is working for you and you're not having relapses because Avonex is effective and then you stop taking it, you're at risk for relapse. On the other hand, if your disease is kind of very quiet and you're in a good long-term remission and the medication wasn't doing very much at that time, then you might not have a relapse. So this is a risk you'd have to take. Personally, I would not take that risk for you. So if you said to me, I'm on Avonex and I'd like to stop, what do you think? I'd say you have to make the decision. Because you have a risk of a relapse. That's the answer. There would be a risk of a relapse.
If you've been on for a long time and you really haven't had any exacerbations, what are the chances if, okay, I'm not going to take it anymore, I'm coming back 2 months later with exacerbations?
I'm not putting a number on that. I would say to you, my answer to you would be, there is a chance. And if you've been stable for 10 years, you've taken Avonex for 10 or 15 years, and you haven't had a relapse for 10 or 15 years, and your scan is stable. So you say, I've had no relapse for 10 or 15 years. You've had no relapses. Your MRI scan is stable. Your examination is good, 10 or 15 years. You stop the medication. High likelihood you'll be fine off the medication, but I'm not going to say to you there's no risk of a relapse. There is some risk.
Approximately percentage-wise?
I wouldn't give you a number. No numbers.
Would you talk briefly about what the latest drugs are in the pipeline?
The latest drugs? Yeah, so, well, if you look at that on the YouTube and look at the list of all those medications that about 4 people could see beside me, if you look at all those medications that I've listed on there, all the approved drugs, on the top right of that, I put 2 of the drugs that are the closest to being approved. One of them is called ocrelizumab. So some of you might know Rituxan. Anybody know Rituxan? Somebody say yes. Even if you don't say yes, good, okay. So ocrelizumab is similar to Rituxan, and then there's another drug next to it called daclizumab. Both of those have completed the phase 3 trials and potentially could be approved in the next year. And then there's other drugs similar to those that are in the pipeline as well. I'd say in the next 3 years, there's about 3 or 4 drugs that are close to approval. And then there's research going on with other things, drugs related to Gilenya, for example. There's some research that is starting with stem cells. I think those are some of the things that come to mind.
Last 2 questions.
Just to further answer that, if you want to look for research stuff, the best place to look for FDA-approved drugs in trials is to go to clinicaltrials.gov. If you go to clinicaltrials.gov, that's all the FDA-approved drugs, all the FDA-approved trials in this country, clinicaltrials.gov.
Dr. Steingo, you mentioned B12. I know most of the time you get it in an injectable form, but what is your feeling on taking it orally as a supplement?
I think many people can take it orally. The only time that so you would take it, let's say your B12 is low, you could take it orally to start with and measure your level. If your level's not going up, that could mean that your level is low because you're not absorbing it, in which case you need to take it by injection. But if it's not low because you haven't had enough in your diet and you supplement it by mouth, you probably will absorb enough. So I'd always say you could start orally. Unless it's very critically low, then I would start by injection. But if it's just a little low, I'd say start by mouth and then check the level, monitor the level. If it's not coming up, then you take then you go by injection.
I was going to ask, what does it mean if your vitamin D is too high?
Too high?
Yeah.
Well, the normal range is that the lab gives you is 30 to 100. If you're over 100, there is some risk for toxic effects, such as, for example, kidney stones. And if it's over 100 for a long period of time, then they write about some other side effects. So we want to keep it under 100. And we can measure it now. That's the good news. So nobody should be toxic because we can measure it.
Okay, thank you, Dr. Steingo. Oh, there you go. So, again, of course, we have to do this at the end of every program, and that is we want to thank again Teva Neuroscience, because we couldn't have done this program without them giving us the funding to do so. So I do thank Teva very much.